Does breastfeeding increase your risk for pelvic floor dysfunction? Hello, everyone. My name is Christina Previtt. I'm a pelvic PT and postdoctoral research fellow in pregnancy, postpartum exercise, and the pelvic floor. And today I want to be breaking down a new systematic review that was trying to elucidate the relationships between breastfeeding and different types of pelvic floor dysfunction. In this paper, they were not able to meta-analyze. They were not able to directly compare control, aka not breastfeeding, to breastfeeding women in the postpartum period because of how much variability there was in this study. But they were able to give quite a few insights, and I have quite a few comments that I think need to clinically be bridged here. So before we get into the paper, when we are talking about why there might be a relationship here, when you are early postpartum, you are already recovering, right? So we have a big stretch injury for our pelvic floor muscles. We have passive tissue that needs to be healing because of things like pushing baby out, right? So vaginal wall range of motion increases, bladder neck is lower, etc. And your body is healing from that on the vaginal delivery side. You are healing from a major abdominal surgery if we went the belly birth C-section route. So there's a lot of healing that is occurring. What happens when you are breastfeeding is that in both, if you're breastfeeding or not, you're going to see a dip in estrogen because in pregnancy, you're basically a ball of estrogen. And then that drops significantly postpartum. And the reason for that is that you don't want to get pregnant again. Not that you can't get pregnant if you don't have your period back or you're exclusively breastfeeding. I don't want you to hear me say that. But the idea is to decrease your likelihood of getting pregnant again so you can heal and take care of your newborn and not think about putting a lot of extra energy into trying to get pregnant again. When you are breastfeeding, right, your body is sending that signal and estrogen gets even lower. So you're in this hypoestrogenic state. And the thought might be is that estrogen is protective around things like pelvic floor dysfunction. And it is protective for things like our bone. And so there's been a big discussion about how your hormone profile in early postpartum very much mimics our hormone profile in menopause. And so the term genitourinary syndrome of lactation has definitely been gaining steam and momentum in the obstetrical space. There's been way more discussion around pregnancy and lactation associated osteoporosis. And this has a lot of implications potentially, especially in our female athlete population who may have a low bone mineral density due to their athletics and underfueling in athletics. So there's that kind of component to it. And then we also know in that genitourinary side is that using estrogen systemically for brain, heart, bone, and on the genitals for the urogenital tract can have positive benefits. So the idea is there any difference in healing and rates of pelvic floor dysfunction when we are thinking about healing in that postpartum period? And so if we look at this study, the area of research that has the most evidence is around dyspareunia or painful penetration and return to sexual activity. So in this study, what they were showing is that 14 out of the 19 studies, and this is still like ahead of print, so it's not even all pretty, were showing an association between breastfeeding and dyspareunia, which is a fairly consistent finding. With this, one of the things that I think truly needs to be differentiated is the time at which they are studying this symptom. There is a difference around exclusively breastfeeding versus when baby starts to introduce food. I have seen an arc in my clinical practice where dyspareunia is higher for my breastfeeding women in that first year postpartum. And so some of these studies were looking later into, 5, 6, 7, 8 years. Some of them are even 12 years postpartum. And so understanding the timeline of these symptoms, I think is going to be really important. And then understanding that when we are looking at pelvic floor dysfunction in the early postpartum period, it is going to be impossible to just link things to one factor because it is so multifactorial. And so dyspareunia is one of these issues. And in the discussion section, they really do talk about this, where it is this hypoestrogenic state, which breastfeeding can influence. It is healing in that postpartum period for sure. And it is hypertonicity as well, not weakness or strength. We're not talking about the strength of our muscles in that postpartum period, but this clenching that can happen, especially when tissues are healing. And then of course our perennial scars and healing perennial scars if there was any vaginal tearing. And so we kind of have multiple things here. What I think is really important to add as well is that the pelvic floor muscles, there was no study, none of these studies reported an association between breastfeeding status and pelvic floor muscles. And so with that, what we are seeing is that we cannot say that postpartum, you cannot gain strength if you are nursing. That is an area that has been kind of like this myth busting that's happened in the strength training space of you'll feel stronger as soon as you stop nursing. And so it's not the pelvic floor muscles. It is likely more some of our static support tissues and our healing timelines when we're in this hypoestrogenic state. And so something for us to be thinking about. The last thing that they really tried to look at is things like prolapse and urinary incontinence, these last two areas. They weren't able to see any association between prolapse and exclusively nursing. Again, that's going to be really tough to tease apart because when we are thinking about prolapse, birth, and these women who are exclusively breastfeeding, have just given birth, are still going to be hugely healing, right? And so understanding that the big influence on your vaginal wall range of motion is absolutely going to be your obstetrical history and what happened during your labor and delivery versus the relative implication of nursing. And then the same is kind of true with the urinary incontinence piece. Now on the UI piece, I think what we need to look at in the breastfeeding space isn't long-term outcomes, because I don't think there's going to be a huge difference around long-term outcomes with exclusively nursing, but early, maybe, right? Because it does keep you in lower estrogen for longer. And so what we need to really be thinking about is that 3-month period to 6-month period if you are exclusively nursing. And then what that looks like from a long-term perspective is probably going to wash out. That effect's going to wash out. Now, what does this mean for your clients on Monday? How do I make you Monday morning ready with this? Number one is understand that association for dyspareunia. So if you are working with clients in birth prep, helping them understand that this is something they may experience is number one. Number two is starting to think about exploring or having your clients speak to the ability to use topical vaginal estrogen early postpartum, right? We don't see any influence of topical estrogens on breast milk or anything like that. So it is safe, especially when it's applied directly to the urogenital tract. A lot of people are starting different types of birth control options at 6 weeks postpartum. It's not influencing breast milk. But I think this is going to be an area where helping with healing by augmenting with estrogen may be helpful. And 3, knowing that it is not a strength issue when some of these associations are being explored, and it's probably more like a passive tissue, low estrogen type of relationship. If this is your body and you are feeling this way, understand that pain with sexual activity in the postpartum period is incredibly common, needs to be talked about more, and is multifactorial. It is your hormones, it is your healing, It is the fact that you're maybe afraid, right? Because if you've had stitches and tearing and things like that, and all of those are very real and very valid. And working through those can take time. A pelvic floor physical therapist is absolutely going to be helpful in this regard. And then having open conversations with your partner around what this feels like for you is going to be incredibly important. Let me know if you have any other questions. See you all next time.